All right. I'm going to get started with just a few reminders for everyone. Thank you for being here. We appreciate you joining us for day three. Before we get started, just a couple of reminders to make sure your full name is in your Zoom profile so we can count your attendance. We ask you have your cameras on when our speakers are talking. We love to see your faces. Please be respectful and attentive to our speakers. Keep yourself muted when not speaking. You can use the chat function to ask or answer questions, and we'll do our best to answer each time permitting. And if you'd like to speak, you can raise your hand and wait to be called on. And then I'm going to introduce our first speaker. So Dr. Ana Maria Robles is the Assistant Professor of Surgery. She's the Division of Trauma, Acute Care Surgery, and Surgical Critical Care at the University of California, Davis. So welcome, Dr. Robles.
Hello, it's lovely to meet you guys, and I'm delighted to be here. I have a couple slides, and I'm going to tell you a little bit about my path to becoming a trauma surgeon. So let me make sure I share the correct screen. Actually, I want to share this one. Okay. Uh, do you see my slides? Yes, you do. Okay,
Yeah,
perfect. Um, so thanks, Sam, for having me. Um, Slides are good.
look good.
Great. So I'm Ana Maria Robles. I grew up in San Diego, California. I'm the oldest daughter of two kids in my family. My dad immigrated from Mexico. He came to the U.S. when he was, he thinks like 12 or 13, but parents can never remember, but he's like 12 or 13. He served in the army. He eventually settled in San Diego. And my mom is a white American. Her family's been in this country a long time. Her parents were like farmers in the Midwest, and they ended up in San Diego because they served in the Navy. So certainly, like a lot of people, have a proud military tradition. And based on what I hear from my parents, they did not have it easy when they got together, especially being from different cultures and different ethnicities. There was a lot of difficulty on both sides of my families. And then also just culturally, living in even in San Diego and in that environment, it was not always a welcome time. I will say this is my little sister, Alexis. I was the first one to go to college in my family. Neither of my parents did. And I was also the first one, as a result, to also go beyond college with all of my medical school and training. So in This is a picture of me in college. I went to the University of California, Berkeley. Like a lot of, northern kids go south, southern kids go north. I was a southern kid that wanted to go north. These are my graduation pictures from high school and college. These were really hard times for me, but also great. I mean, but that looking back, they're really hard. In high school, I went to a pretty poor high school in general. Like I think half of the people at my high school didn't graduate that we started with 800 and they graduated 400 of us. And a lot of that was because it was a difficult environment. People were poor. A lot of young women getting pregnant and having to drop out or go getting their GEDs. But I always felt like both this was me and this was my community, but that I wanted to achieve. And I wasn't sure exactly what. I kind of always thought I wanted to be a doctor, but I didn't know any doctors, other than my pediatrician. I didn't know anybody that had taken that path. So it was really difficult when I was young to be like, okay, yeah, maybe I want to be a doctor, but I'm scared to say it out loud because what if I fail, right? That is something that can be so, so difficult. And also, like, I have no idea how to even begin to get there. So let me tell you a little bit about how I got there. So I went to San Diego High School, which was my high school downtown. And then I came up here, and I've been up in Northern California since. So for actually, my mother tells me longer than I lived in Southern California, but it's always home. I went to Cal, Berkeley, and I got my biology major at Cal. The one of the most important things in college, it was so overwhelming because Berkeley has, I went from a school of like 2,000 kids, which was a pretty good sized high school, to Berkeley, which had like 40,000. And it was so overwhelming to be in these like classes with 400 people, and everybody seemed to be really driven and know what they wanted. And the only way I got through Cal was finding community. I was involved in some groups that were actually centered for first generation, underrepresented in science. I got invited to these groups and I said yes, and thank goodness I did. Because they help break it down. The group at Cal is called Biology Scholars. They have different types of versions at every place, and it's a known thing that young folks that particularly that are underrepresented that are in college tend to drop out of science majors, right? Because it's hard and you don't know exactly what's expected of you and you get discouraged and then you just leave. And that happens all the time at Berkeley. But because I was able to get in those groups and find a community, I was able to help figure it out. I was able to feel open and ask questions and ask for help. And I went to tutoring for the first time in my life. And that's what helped me get through Cal, being really honest and open about my community, but also with myself and learning about myself and what I really wanted. I was still too scared at Berkeley to ever say I was a pre-med. I was not one of those Berkeley kids. I was too scared to say it. But I sort of took all the classes and then through the Biology Scholars Program, they helped me subsidize like taking an MCAT review course, and I took the MCAT, and I got a job after college because it's really, one, I needed to work and make money, but it's like expensive to apply to medical school. So I took that time. I worked at Oakland Children's Hospital. I met some doctors, and I was like, okay, I worked for these doctors as their research coordinator, and I was like, okay, do I like this? What is their life like? Do I like being around people? Do I like working in a hospital? And that was my time to really figure those things out. Some people could do all of that at the same time as they're going to college. College was enough for me, and I needed that time after to kind of re-explore what I wanted myself. So I took 2 years in between college and going to medical school. I went to med school at UC San Francisco, which was awesome. And med school was really interesting because all of a sudden you go from in college being in like 40,000 people in giant rooms to you're in a med school class of only like 150 people in your class, and you really get to know them. And I like I loved biology, but I really love medicine. And it was awesome to spend time in school thinking everything I'm learning is going to make me a better doctor. Everything I'm learning is going to help me take better care of somebody in the future. And I found that like so motivating in a way that like I'm not a physics person. Like I'd be like, why am I learning physics again? Like, why am I memorizing these equations? And it was harder for me to pull that into my life. But in med school, I really felt like, wow, everything I'm learning, everything I'm getting the chance to figure out is directly applying to how I'm going to take care of patients. So med school is 4 years. So I spent 4 years in college and then 4 years in med school. And then in med school, I met a trauma surgeon at San Francisco General Hospital. His name's Andre Campbell. He's awesome. And he talks a lot on the news and other things. So if you want to listen to somebody that's awesome, um, I would listen to Dr. Campbell. And he kind of changed my life. In med school, I thought I wanted to be an obstetrician. I thought it was a great way to live my values of social justice, of care for women, and really being there for people at critical times in their life. And then I met Dr. Campbell, and he's a trauma surgeon. And I was like, this guy can take care of anything that walks in the door. And he really, truly, he's a black man from New York City, and his heritage is Jamaican. And he lives his truth and he lives himself. And I was so inspired by that. I actually totally changed my career trajectory. I applied to surgery, general surgery then. And I was lucky enough actually to stay at the same place at UC San Francisco, which was a great training program. So general surgery training at UC San Francisco, which is an academic center, is 7 years long. So after 4 years of med school, then I spent 7 years in residency. Um, First year of that is your intern year. Then you spend total 5 clinical years and 2 research plus clinical years. And it was great training. We trained all over the city, both in private and in public hospitals, got a great training in trauma. And general surgery really is like operating on a lot of the abdomen, but also sometimes arms and legs. We don't tend to fix bones, but sort of jack of all trades handling things in the hospital. Residency's hard, but it was a great experience. And you do that it was a group of 7 of us, and then there's 7 different years. So you're getting into these progressively smaller little silos. After residency, I still love trauma surgery. Everyone says like, oh, you'll fall out of love with it. You'll want to do something else. But I still loved it. So then that was when I came here to Sacramento. I matched as a fellow here at UC Davis. I did 2 more years. This training is endless. I finally finished in 2020. This whole process took 17 years from when I finished high school. But finished, did 2 more years, one in the ICU taking care of surgical patients, and then went on trauma and acute care surgery. And that's where I work. I got hired here after that time, and I've been working here in Sacramento since. A little bit about my training. These are two of my co-interns. So we went through the 7-year training program together. This is a picture of me operating with one of my chief residents. Um, Training in surgery is an awesome experience. You get to do a lot of operating, but you also spend a lot of time taking care of patients, rounding on them, writing notes, calling consults, talking to social workers, talking to families. Like all of that is also part of medicine. And both of those things are why I love surgery and trauma surgery. A little bit about my daily life. My daily life then as a resident and still now is doing all of those things. So it depends a little bit on what I'm doing. If I am on a service that is operative, either taking care of like taking out, 2 nights ago I was on call and the guy came in with appendicitis. We took out his appendix. Seeing patients that come through the emergency department that may have problems, either they're injured or they have general surgery problems. Those are patients that we take care of. If they need to go to the operating room, we take them to the operating room or we find whoever needs to do that. Spend a lot of time taking care of teams. So on a team of people, leading a team of people. When I'm on trauma, it's me leading a group of residents and nurse practitioners. We seeing all the patients, talking to everybody, figuring out plans. Okay, when is their leg going to be fixed? Okay, did they clear physical therapy after they broke all their ribs? Is their pain controlled? Can they go home? Do they have a safe place to go? Did they break all their legs and they live on top of like a 3-story building? And so how are they going to get up top? All of those problems in addition to operating. Spend a lot of time in the hospital rounding on people. I'm also roles that I've taken on since being here at UC Davis. I'm the director of our surgical ICU, and I run our fellowship for the same fellowship that I did a couple of years ago. So in the ICU, I spend a lot of time taking care of our sickest surgical patients. People that are injured, that have breathing tubes in, people that are super sick from infections, people that have had vascular procedures, liver transplant, kidney transplant. I get to take care of those people as the ICU doctor, also with a team of people. Somewhat different teams. Usually that's with a fellow and some residents and also nurse practitioners, but I also spend a lot of time working with physical therapy, my ICU nurses that I'm very, very close with. Um, I consider them part of our family as well. Respiratory therapists, and it takes a whole team of individuals to take care of patients at a hospital like this. Here at UC Davis, we're a level 1 trauma center for both adults and kids. So I take care of people from the entire region of Northern California. If they're injured and anybody that's severely injured, they pretty much come to us. Sometimes they go to another hospital, then they call us, and then we bring them down. And that's both adults and kids. When I say injured, I mean all kinds of things. Were you hit by a car? Did you fall off a mountain? Were you shot or stabbed? Anybody that is hurt at all, those are people that I take care of. And it's really a privilege to take care of them at like the most vulnerable times of their lives. Some of the challenges, residency is really hard. Surgery is really hard sometimes. We get up early, right? The operating room start at 7:30, so you got to see all your patients before then. So we get up, we get up pretty early. We work really hard. Sometimes operations, can take a long time. Every day you're learning, right? Every day you're trying to figure out, how do I do this better? How can I take better care of my patients? How can I make sure that I'm doing what needs to be done? Did I do the right thing? Did they heal? Did they not heal? And the other thing that's things about trauma that are specific and challenging is, sometimes you were out, you weren't sick before usually, right? You're out living your life and then you're hit by a car. And then suddenly you and your family are trying to figure out, like, what does that mean? Are they ever going to recover? What does that look like? So we spend a lot of time dealing with really difficult conversations with people, breaking bad news, all of those things. And it's hard to do that most of the time, but it's particularly hard to do that when you're super tired. But it is a wonderful thing to be able to be there for people. Some of my motivation in this job, some of it's my family, and also my friends and my co-residents. My grandfather got to see me graduate from college. I'm sorry, graduate from med school. This is a photo of him. My grandma didn't make it. She died when I was in med school, but he came up to see me graduate from med school, and he didn't even go to high school, so He got his GED eventually, and he's a very smart guy, right? Like a lot of us that are first gen, it's not a surprise. Like, yeah, you're the first one to finish college, but you're smart because of all the people in your family that are also smart just because they went to college or not, right? Like they're still incredibly smart. My grandpa could do math better than I could at any point in my career. Um, but my family, my mom and dad, my sister went on and she works in health policy and law and got an MPH down in New Orleans and is like I'm so proud of her and I'm so proud of both of us that we were able to achieve. And then also like my friends and co-residents. You get really close after 7 years with people, spending late nights, working overnight, seeing them the whole time, and then all of my mentors. This is actually a bobblehead of that guy that changed my life, Dr. Campbell, up here that somebody got him. And then my current boss, who's been my boss for almost 12 years and has really hired me and guided me through everything, is also up here in the second from the top. These are all wonderful mentors, and really having everybody that believes in you and sponsors you is like so important. And my last two things and is my husband. He's a firefighter, so he like understands the life a little bit. But our life is super chaotic because I also have two very sweet babies that I had since I came here to Sacramento, actually. Being a mom and being a surgeon is those are kind of the two things that overwhelm my life right now because my babies are very small and they need me. But they're the two greatest gifts, right? They remind me that my job is not, it is everything and it is something to take serious, but it is not the only thing in my life, right? And they give me motivation to do better and to be better, but also to be present and to take good care of myself. Because I can't just go home and crash the way I used to before I had them, right? I go home and they want me and they need me. So I've been able to, I think, give them a good life and continue to do so as their mom. And I'm like so proud to be able to do that. So this is a group that I work with. You can see like we're all pretty different. These are my fellows in the front row, and I'm so proud to be training them. That's my boss. That's me, Dr. Brown over here. He and I met when we were residents. I was his intern when he was a chief, but everybody does great work in taking care of really injured people all across the Northern California region. And I'm so proud to work here and to work alongside them and to get to train some of these awesome, awesome fellows. And to always keep in mind like how important it is that we get to do what we do. So that's a little bit about me. I'm so glad you guys are here and getting to learn about medicine. I'm going to stop sharing and then I'm happy to take questions that you have. Anything medicine,
Anyone
surgery,
have any
trauma.
questions? We'll give them a minute. You can put them in the chat. You can also raise your hand. Anything about trauma surgery?
Or
Jillian?
Okay, so like I know you're kind of talking about it, but can you like clarify like what exactly is trauma surgery? Is it like general surgery except that your patients may have gone through a really traumatic experience, so you may have to help them cope with that? Like what's the
Oh yeah,
difference there?
that's a great question. So general surgery is the overbearing category. All trauma surgeons are general surgeons, but not all general surgeons are trauma surgeons. General surgery means you are facile at operating in a variety of different parts of the body and that you're skilled to do that. So I am a general surgeon. I did specialized training in the ICU and trauma. And when I say trauma, I mean injured. So people that are injured in a variety of ways. So my specialty is taking care of people that have been shot, have been stabbed, have been run over by cars, have been in car crashes, because there's certain things that come with that, like the way your ribs break. How do we fix your ribs? All of that is part of trauma surgery. If you start bleeding from your liver, how do you manage that? How do you take care of it? Um, is somebody's spleen bleeding because, I don't know, somebody whacked them with a baseball bat at practice? How do you manage that injury? So that's a lot of what I do in my job. But I also do general surgery and something we call acute care surgery. So all the surgical emergencies that happen, that is part of my job as well. So those are some of the pieces. It's mainly being on call and dealing with whatever kind of rolls through the door that is urgent and needed. See some questions in the chat. Do I work on a set schedule or do I work shifts? I do work on a set schedule and I work shifts. So, and then the second question is also how long do your shifts range and what is the longest shift you have worked? So mine is very, because I'm an emergency doctor, I do work overnight shifts in addition to daytime shifts. Because there always has to be a trauma surgeon and always has to be an acute care surgeon in this hospital as one of the trauma centers. So the way my life works is on a given month, say I'm on service. So that means every day I'm taking care of people in the hospital, whether that's on trauma or in the ICU or on surgery. And that's more of like it's our version of 9 to 5, which is really like 7 to 6-ish. And I'll do that like every day for a week because you want to be like taking care of them and saying, okay, next day I did this day. This is how I'm going to change them the next day. Also seeing people that run through the emergency department. Um, when I go home, like if I'm on trauma, I'm on during the day and then I hand off to one of my partners overnight. So somebody else comes in, works at night, gives it back to me in the morning. So in the weeks where I'm not on service, I'm that person. I'm the night person. I'll come in at 4, get the phone, see everybody that comes in overnight. In the morning, I'm like, here you go. And then I go home and sleep. Usually I did that Monday night because I'm not on service this week. It also gives me time to do stuff like this when I'm not on service. So the night shifts are usually like 4 to 8 a.m. And I work 1 or 2 of those a week when I'm not on service. The longest shift I've worked a lot of like weekends where you were kind of here the whole time and you got very little sleep. So it's probably somewhere like in like the 48-hour range. But you're not super firing on all cylinders by the end there. And usually you're like, I'm great. I know exactly what I'm doing. And your partners are like, go home, you're tired. You don't make any more sense. But sometimes you do when you're on call, you spend a lot of time with places.
You have a
Question.
hand up?
Yeah.
Yeah.
Hello, doctor. So I had a
Hi.
question specifically about, I guess maybe when you were getting first into trauma surgery, were you ever afraid of like blood or needles when you were younger?
Not afraid of blood. You never really know until you see it. You're like, oh, I'm not really afraid of blood. Or like my cousins, they'll like run out of the room. Um, Needles. I did not love needles growing up. I don't know anybody who really loves needles, to be honest, but I wasn't like pathologically scared of it. Um, But you learn some of this in med school because you spend in med school like your first 2 years are learning about the body, but your second 2 years you're in the hospital doing like you do a bunch of different rotations. You do like a surgery rotation and a peds and an OB and a medicine. And you kind of get the chance. Well, I see this with med students that rotate through surgery. Some of them like don't like blood or don't like poop or don't like the gore and guts. They're like, no, thank you. And I'm like, okay, that's fine. Like, learn what you got to learn. And then you go off and become a fantastic pediatrician that rarely deals with that, right? Or a radiologist that like doesn't see patients but is brilliant and can like put the pieces together, right? So there's a part for everybody in medicine. No, not everybody has to love it. But you get the chance to kind of do 4 weeks and you can be like, okay, I really like this. Or, oh, actually, I don't like, I did not have fun on pediatrics. I was like, I cannot do this job. Or psychiatry, I did not have fun. But some people love it. And that was your chance to kind of be like, okay, I'll learn what I need to learn, but this is not for me for whatever reason. Blood, guts. I get like bored very easily. So people would be talking and I'd be like, rounds are taking too long. I'm hungry. I want to go do something, right? Like surgeons tend to be, let's get it done. Let's get going. Let's go, go, go people. That suited me, but it doesn't suit everybody. So I think that gives you a chance. But there's still stuff that grosses me out, I will admit. I see a lot of gross stuff. I do a lot of gross things in my job, but there's always something that can gross you out. And you're like, huh. But I sort of think about it academically now. I'm like, oh, that's a very interesting problem. While other people are like puking in the trash. Hazel.
Hi, doctor. I
Hi.
was wondering, do you think that you really have to love like all of the kind of more gross parts to be a trauma surgeon? Because personally, I think that I'm like pretty interested in that kind of thing, but like when I talk about it, other people are like, "Oh, that's you shouldn't do that." But
You have to love something about it to do it, right? Because it's hard work. So you got to have some kind of drive. But there's definitely like medical people are different and different specialties have their thing, right? That like they really love and other people don't really love. And that's even true within different types of surgery, ear, nose, and throat doctors, urology, orthopedics. Like There'll be parts they'll be talking about something. I'll be like, that is disgusting. That is terrible. But then I'll talk about something and they think what I'm doing is terrible, right? Everybody's different. And I think that is like one of the beautiful parts of medicine is we need everybody to take care of people and everybody's different strengths and skills. So I think that is like very cool. But there's a part for you, whatever you find gross or not gross in medicine. There's a piece for you there. Surindi, I think.
Yes. Hi, doctor. So I think you mentioned earlier how sometimes there's some cases where like something grosses you out or something. And I wanted to know like how do you deal with that and like how do you kind of like combat that? Because obviously in front of the patient you can't react or like act grossed out. So what do you do in that kind of situation?
For the most part, and this is true about if something is gross or if something is hard, but often not much grosses me out anymore, but something that still gets me is stuff that's really sad. Um, because as you might imagine, right, I'm taking care of people that have been injured. So there's sometimes really sad stuff around that. Um, I try to think, uh, one is experience. The more you see something, the more you kind of gain experience in how you deal with it, right? Like it's just that's what training is. That's part of what you're doing in school. You're learning stuff. Like that's why we do so much training after to get to the point of being a doctor so that you get used to it. So some of it is you getting used to it and seeing different things. I think the other thing that I try to think about, particularly when something is really sad and I'm feeling sad, is like, does my sadness help? Like, does that help them? Does me having a big emotional reaction right now help me take care of this patient? And if the answer is no, then in my head, I'm like, okay, that's something for later. And you still have to get it out, right? You still have to be a healthy doctor that is able to take care of other people. So just squishing it down forever and never dealing with real normal feelings doesn't really help anybody either. Eventually you'll burn out. Eventually you won't be able to handle. But I think like, is this helpful to the patient right now? And if it doesn't, because of that training, because I've seen this now and I've worked the long hours and I've done it and I continue to do it. I'm not perfect at this. Sometimes stuff gets you, and I'm a work in progress. Um, I table it for later, right? Okay, maybe I need to call my dad driving home and just cry or be sad about something, but it's not going to help me take care of this patient right now. They need me thinking clearly. They need me making good decisions. And keeping that patient as like the forefront of what I'm doing has always helped me as a doctor. Everybody has different things, but has helped me as a doctor function even when things get really hard. Because they need me to make good decisions, right? They don't need me to be sad or upset. It doesn't help them.
We have time for one more question from Jillian,
Awesome.
then we have to
Thanks,
move
Sam.
on to our next
Thanks,
speaker.
Jillian.
Doctor, I just had one more question. During those 2 years you took between college and med school, and you were kind of deciding exactly what you wanted to do, what kind of things did you do?
Yeah. I got a job working as a clinical research coordinator in actually cystic fibrosis at Children's Hospital Oakland. Lots of people that are interested in medicine do that job. I have a bunch of people that work with me on our research that also do that. And they come in and you learn how to run some of the trials and deal with people, but you also interface with the hospital system and doctors. And kind of gives you a chance to be like, do I like this? Do I not like this life? And then also it's a job and you make money and then you can go on and figure out what you want to do. I've had people in our lab that have gone on to medical school, but also getting their PhDs, nursing, and I've had like one physical therapist. So it's a good time.
All right. Well, thank you very much. Please, everyone, thank Dr. Robles for
Thank you guys. It
sharing
was a
her
pleasure.
specialty. We appreciate your time. Thank you so much. All right, we're going to move to our next speaker. So Dr. Tyler Sullivan is an emergency medicine physician. So kind of carrying on from the emergency care. He works in the Sutter Roseville Medical Center and he's with Vituity. So welcome, Dr. Sullivan.
Hi, everyone. Thank you for having me. I'll just start by saying a little bit about myself. So I'm 34 years old. I went to high school in Elk Grove, California at Elk Grove High School. Was interested in the sciences, but didn't really know I wanted to like go into the medical field per se. And then I went to Sac State. I was a bio major there. And quite frankly, I didn't, do super well in school. I didn't have my my focus down. So I could have done a lot better in undergrad, but I was still getting by, and still knew I wanted to pursue medicine in some capacity. I just didn't know whether it was going to be a PA or pharmacy or medical school. And then, for me, it just took a trip to like a medical mission to Ecuador for about 6 weeks. And that was with a bunch of medical students, where I met them, and I had a lot of time to kind of introspect, reflect on myself and where I was going. I was probably 21 or 22 at that time. And so I came back really refocusing myself and my vision and my career path. So I did really well in school once I came back, but it wasn't enough to kind of fix my GPA as well enough as it needed to be to apply for medical school, because there's very strict standards to get in. So I did kind of an alternate route. I took 1 year off after graduating undergrad, and I worked at the coroner's office. And I was also working as a medical scribe in the emergency department. And I think that was my first kind of introduction to really a clinical setting in the emergency room. And that's how I found out what an ER doctor does every day. Because my parents weren't in the medical field. I didn't know any doctors in my family. I didn't have any friends as parents who were doctors, so I was kind of going in a little bit blind. But I took that year to refocus myself, and then I applied for a master's program in Vallejo at Toro University, California. And I got into that school, and I did really well in the master's program, and then they accepted me into their medical school. So I finished that, graduated medical school, applied for residency. I met my current wife in medical school, and she's also a doctor. She's a hospitalist, an internal medicine doctor. And so we applied together to residency, ended up in the same city in Fresno, where she did her internal medicine training. I did my ER residency training. We both did for 3 years. We graduated in summer of 2024, and then we got our first jobs here in the Sacramento area. She's at Sutter Downtown, and I'm at Sutter Roseville. So that's kind of my course to where I am today. But day-to-day responsibilities as an ER doctor, we have really good coverage at Sutter Roseville, but typically you'd show up to a shift and there's patients that are waiting. The nursing staff has done their job triaging patients, taking vitals, writing down what the chief complaint is, why someone comes to the emergency department. And then there's a list of patients that need to be seen. We call them REDs at Sutter Roseville. So there's REDs that need to be seen on our tracking board. Sometimes I'll start a shift and there's 4 REDs on the board, 4 patients waiting to see a doctor. Sometimes I've walked in and there's 25 REDs on the board. So it can really vary depending on the day. Just a tidbit for you guys and your lives. If you ever have to go to the ER, the best time to go is at like 6 a.m., like 5 a.m. to like 7 a.m. You're going to get seen really quickly. And Monday is always the busiest day in the ER. Who knows why? Probably because, they didn't want to come in on the weekend when they have the days off. And then, you have to go to work and it's, maybe you need a work note. There's various reasons, but everyone knows Monday's the busiest day in the ER. Anyways, so I'll be responsible for the REDs that are on the board when I show up to my shift. And we do something in the ER called triage. So it's one of the times where in medicine, we try to stick to like non-maleficence, like do no harm, treat everyone fairly, do justice. but triage is one of the areas in medical ethics where you're allowed to not treat everyone fairly, per se, is the sickest patients get seen first. So even though you might have been waiting for 2 hours and you're next up to be seen, if somebody walks in and they have a life-threatening process going on, unstable vitals, that unstable person is going to be seen first. And it's well accepted in the medical community that's what we do, and that's fair. It might not seem fair sometimes to the person who has been waiting longer, but it's best for the general population who's in the emergency department when those sicker patients get seen first. So we triage patients. So I'll look through those reds and see who looks sickest. And if everyone seems relatively stable, then I'll start from the longest waiting. And then you work through it. You have to be efficient, and you have to be relatively quick. I certainly would love to spend more time with almost every patient that I see in the emergency department, but it's just not feasible with how many people are coming into the emergency department. Typically it'll be maybe 7 minutes in the room, seeing them, general idea, what brought you in? Why do you think this is an emergency? And I'm doing an assessment. I'm looking at the way they're breathing, the way they're moving. I'm looking at family in the room, trying to just kind of gauge what the situation is and whether I think this is an emergency. Could this be an emergency? Maybe they don't think is one, but maybe there's something else going on. So all those things are going through my head when I'm asking them directed questions. And then I'm doing a quick physical exam focused on the systems that are related to whatever they're coming in with, and then putting in orders. And then I'm moving on to the next room. But that patient's my patient now. So we usually have to work pretty quickly in the first couple hours of our 8-hour shift, and seeing, maybe 16 patients in 2 hours. And then once those 2 hours are over, we're looking through that list. Some lab results might start to come in, and some x-rays, CT images start to come in, and we address things as they come up. In the emergency department, they sometimes refer to us as we're the jack of all trades, but we're not super great at everything, frankly. We just kind of know a little bit about everything of different specialties. But our core specialty comes down to managing emergencies and resuscitating patients who are unstable, getting them stable enough to move on to the next place, such as the ICU or being admitted to the hospital. So whether that means fluids, starting them on vasopressors, getting a breathing tube, getting them intubated, or doing minor procedures, laceration repairs, paracentesis, thoracentesis, lumbar punctures, draining abscesses. We have a list of kind of procedures we're able to do, which is growing every year. Just last year, the emergency medicine oversight people, they just added a bunch of procedures that we should now be able to do that maybe I didn't get trained in when I trained, and I'm sure there's going to be more that come up. So it's a evolving specialty. It's a relatively new specialty. It was born in the 1970s, I believe. So it's relative to other specialties, it's a little bit newer. But yeah, I think it's one thing, you think about the reasons why you go into medicine, and you want to do the best for people. And the things I really liked in medical school and stuff while I was on clinical rotations was connecting with people, following people day to day, and establishing a relationship with them. That's one of the things I knew I was going to be sacrificing going into emergency medicine, because most of the time, the people that I see in the emergency department, I'm not seeing again. I'm seeing them the one day. I'm usually just seeing them during triage. then maybe reassessing them a couple times throughout my shift. And then unless they're someone who comes in the emergency department regularly, or if they're just a sick patient who's well known to our population and they're always in the ER, sometimes I'll recognize them or they'll recognize me when I walk in the room. But you kind of lose that, it's much different than like family practice per se. Outpatient, you have a doctor, that's your doctor. But when you come in the ER, there's many ER doctors that work with me who you might get to see. And we're not kind of like assigned like that. It's just you get who you come in for. So I wish I could spend more time with them, but we have to just prioritize, the acuity of the patients that come in. So other responsibilities throughout the shift, we're getting calls from primary care physicians that are calling in and saying, hey, I had this patient in the clinic today. I think this is going on. I'm sending them to the ER. I'm worried about this condition. So can you make a note in their chart so when they show up to the ER, you get this test? Sure. So we're taking phone calls. We're taking phone calls from the radio, from the paramedics who are out in the field. Sometimes they want to, they've ran through their algorithms for how to manage patients in the field if they've suffered cardiac arrest and they want to call time of death. Sometimes they call us for assistance or guidance. Should we call this patient? Should we call a time of death, pronounce this person dead, or should we bring them to the emergency department and have your team look at them? So we'll make calls. We'll discuss with paramedics. And paramedics often will also call and use our assistance if patients are in the field. Someone had called 911. Hey, we think you should go to the hospital, and then the paramedics get there and the patient says they don't want to go to the ER. Well, if sometimes the paramedics can determine capacity that the patient can make that decision or not, but sometimes there's not everything's like super black and white, in real life. So sometimes they're not meeting a certain criteria where the medics think that it's safe for them to just sign a form and go home. So they want the doctor to weigh in on it. And sometimes we'll just talk to the patient on the radio and say, hey, we really think you should come in. And they'll just say, oh, okay. And I said the same thing that the paramedic said, but I guess it's just because it's a doctor saying it. But sometimes we really have to have long discussions with patients and, tell them why we think it's important for them to come in or what we might be concerned about. But yeah, our patient population in the ER, we're putting out fires a lot. And that's a metaphor. We're putting out fires. There's a lot of things going on in the hospital, in the emergency department. There's family members who get agitated and upset. There's, sometimes patients come in under the influence of alcohol or drugs. Sometimes they're undergoing a psychiatric emergency, and, the ER is a catch-all for police, medics, psychiatric emergencies, traumatic injuries, and then medical emergencies too. It's kind of the front door to the hospital. And we kind of decide who stays in the hospital and who gets to go home. But so we have to respond to different situations in the hospital and in the emergency department, often with little to no information of any background. And in those situations, you just have to make a decision that's reasonable at the time of. And this was a thing that was very difficult for me to conceptualize growing up, because I've been so OCD about everything, about school, about learning things. Like, I want to know all the information before I make a decision and put my name on something. But truly, in the emergency department, what people need in the moment is for a decision to be made. And when those decisions in an emergency have to be made, you have to just go off of limited information at the time of. And the most important things in those times are just the vital signs. Like, are the vital signs stable? is their airway protected? We run by ABCs, like airway, breathing, circulation. That's what medics run by. And so that's when I respond to these things. Is their airway intact? Are they breathing? Do they have breath sounds? Is their circulatory system intact? And then we have verbal de-escalation techniques. Sometimes we have to use chemical sedation to stabilize situations, but it's a lot. You have to have pretty good social skills, I think, to kind of assess situations and deal with people, some like on their worst day of their lives when they come in the emergency department. There's highs, there's lows. People come in, they're just kind of joking around sometimes. Other people come in, they think they're having a miscarriage and, they really wanted to have a baby. And so you're bouncing from patient to patient who just completely different vibes, and you have to just mentally shift what you're going through. So it could be very taxing on yourself and your mind. And so it's been nice to have my wife also in medicine, where I can talk to her about, what's going on at the hospital, patients that I saw that day, to just kind of like as a sort of therapeutic conversation. And she understands what I'm talking about, because like once you get really down in the weeds of being in the medical field, you kind of have your own language per se of like medical jargon. And, when I talk to my friends from like college and stuff about medical stuff, it's like, oh my gosh, this is so crazy to me. And I'll tell the story to them and they're like, wait, what's so crazy about that? And I'm like, well, but it's getting into the medical society, into the medical field is very niche. And, you use other people in the medical field to kind of cope with things that you see and things that you have to deal with on a daily basis. So one thing, any advice for students interested in the healthcare career, I think is just take the time as early as you can to think about what specialty you might go into. I know that sounds like so early to be thinking about, but once you like go in, that's like what once you like start the path, that's what everybody's going to be asking. And everyone is asking me. The only experience I had was with forensic pathology, working at the coroner's office and working as a medical scribe in the emergency department. So that's all I had to go off of and to think about, like if someone would say, what do you think about cardiology? I had no idea. I don't know what a cardiologist does every day. What do you think about psychiatry? I have no idea. I've never seen a psychiatrist. I don't know what a psychiatrist does every day. So the more chances you can get to even if it's just one day shadowing a specialist, and when you see them, just like look what they're doing, look how they seem like mentally, how if they seem stressed out, if it seems like your personality could like handle or would coincide, would be good working as that person, and ask them, sometimes difficult questions like, what do you enjoy about it? What concerns you about your job choice? What you like about it, what you don't. So try to get those experiences early so you have at least an idea what each specialty is about, so that you make informed decisions and you're not like scrambling at the end like I was to, choose a specialty. Because if you are going the medical doctor route, it's once you finish medical school, you choose a residency. Once you're in residency, that's when you choose, that's your specialty. If you want to change specialties, like for instance, if I wanted to say, I want to be a cardiologist, or I want to do what my wife does, I want to be a hospitalist, I would have to go redo residency completely. And that's a whole 3 years. I can't just be, I'm ER, now I want to go do this. You have to go redo a residency, and residency is minimum 3 years of training. So
We have a
I would
question
say
in the
that,
chat.
and then just know about them. Just know that there's a lot of medical insurance, like student debt that goes into it. So you just really, you got to be all in, you know, because that debt will follow you if you end up changing your mind. So I'm working on paying off my debts. It's just a lot, you know, to go into, and that's why medical schools really, they want you to graduate once you're accepted, but they just want to know that you've really thought out the other options and that you're really committed to it. And one of those things is the financial obligations of the loans that you'll have to take out to undergo the schooling, because during medical school, there's just no way you can like have a job unless you like work in the library at the medical school, and you could like study, you know. But those are the only jobs I saw people doing where they could make some money at the same time, but that's not enough money to like pay off your loans.
We have a
So,
question in the chat.
yeah.
What is your mindset towards the more severely injured patient?
My mindset is, like we said, like the ABCs. So if I think somebody's very severely injured, I'm thinking, do they have stable vital signs? Is their airway intact? Do they need a breathing tube? Do they need intervention right now? And then what diagnostics might I do to assess those injuries, x-rays, CT scans, labs? And then do I need to get any specialists involved? Like at Sutter Roseville, I usually have a pretty low threshold if someone's severely injured to call the trauma team. And then obviously get their pain under control, communicate to the nurses to be rechecking their vital signs to see if there's any changes. So I might have them be rechecking their vital signs every 15 minutes or so, especially if they're critically ill, came in as a trauma. Yeah.
We
We have another hand up?
We have a hand up, yeah, and then we have one more question in the chat as well.
Okay.
Hello, doctor. So I had a question about specifically your mindset. I know as an ER doctor, you often have to make like rapid decisions. I would assume so. And
Yeah.
I was just wondering specifically, have you always been able to like think very quickly in these stressful situations, even since you were little? Or has this been
No,
something oh no. Okay.
it's definitely training. And like I was kind of saying a little bit earlier, I don't like making the quick decisions like that because I'm like a little bit OCD. I want to have more information before I'm making big decisions. But part of the training you get in emergency medicine is being able to make those quick decisions, and just trying to do what's best for the patient in that moment. And a safe thing to do in those moments are go back to the fundamentals: airway, breathing, circulation, because if those things are messed up in any way, those are the things that can make people die if they're not. So, okay, is their airway intact? If it's not, then you intubate them. If their breathing's not intact, they might need to be intubated, or they might need a chest tube emergently, or needle decompression, or they might need hemodynamic support with vasopressors. But it kind of comes down to like there's like different schools of thought with like cognition and decision making capacity or decision making in the emergency department. Most of the time in life we can kind of be on autopilot. Once you've seen a certain amount of chest pains, a certain amount of elbow pains or headaches in the emergency department, I'm going to be able to do the same thing I do on most people most days, and things are going to be fine. But sometimes we have to switch into a different like school of thinking, like a little more critical thinking skills. And I probably have to switch into that mode of thinking maybe 10 to 15% of the time of our shift. But those are really the key times where this patient needs a doctor. Otherwise, it's relatively algorithmic what we do. There's very standardized workups for like someone that comes in with chest pain. It's going to be an EKG, a chest X-ray, a troponin, basic labs, maybe an aspirin, right? So like a computer could do that. But sometimes there's something a little more nuanced and about the patient. And often there is. Like everybody's an individual. Everyone has something different. Maybe they have this different disease process. They've had something cardiac or lung, something in their chest before some disease process that I have to take into consideration. And so I have to switch out of that algorithmic mindset and into something a little more nuanced and think a little more like a doctor and critically think about this. But in those very acute moments, you have to just make a quick algorithmic decision.
Jillian?
Yeah.
Hi, doctor. So, I mentioned when you were talking, like you said sometimes that you'd have pretty dangerous situations, like there may be someone who's drunk or there's someone who's on drugs come in. How do you handle those like dangerous situations?
Yeah. So frankly, most of the time, by the time they get in the emergency department, they've been triaged. So they've already passed through our security team. And those people who are really like getting worked up, they've already been identified by the team. So by the time I'm coming to bedside as the doctor, they're already either in restraints or there's security at bedside. So, it's not like, I've never had a patient like swing a fist at me or anything like that, but there's been times where I thought they might, so it's kind of just walking up and understanding that this person could be agitated. They could be labile. They're not thinking how clearly they usually do. And they might look at me as threatening when I walk up. So trying to get on their level, maybe take a seat, but in a safe place of the room, closer to the door, and trying verbal de-escalation techniques, also taking into account what the nursing staff has said. I'm going to walk up to somebody who's already punched somebody way differently than somebody who said, hey, they made a comment that was kind of, I think they're a little ticked off. That's a lot different, right? Someone's already shown evidence of violence. So it's tough to gauge those situations, and we try not to do physical restraints as much as we can, or chemical restraints like medications to calm people down. But sometimes it's when you're putting the other staff at risk for violence and getting hurt. That's what we have to do, and it is medically justified. And most of the time, just last week I had somebody who came in. He was out of control, screaming in 4-point restraints. Young guy, he was like 26, and like really nice clothes, but he couldn't say a single word. I couldn't make out a single word he was saying. He was screaming and thrashing about. And after my night shift, I went and saw him in the morning, and he's, yes, sir, yes, ma'am, shaking my hand. I'm so sorry for what happened. I'm so embarrassed. He was just a completely different person. I didn't even recognize him. So just understanding that, people are just he was embarrassed, so people make poor decisions sometimes, and then they're not acting like they'd like to. So it's just trying to be respectful of them and not do any harm to them at the same time.
All right. Well, thank you very much, Dr. Sullivan. Everyone, please thank Dr. Sullivan for sharing this. This was an awesome compliment, and actually it will transition well. Our next speaker is an EMT paramedic. So we'll get to hear from that side as well. So thank you so much for your time. Thank you for joining us. We really appreciate it.
Thank you, everybody, and thank you, Sam, for the opportunity. Thank you.
All right.
Bye.
So we're going to transition into our next speaker. So Alex Lee is a firefighter paramedic with the San Jose Fire Department. Previously, he was a CPR instructor and 911 ambulance transport with American Medical Response. So welcome, Alex.
Hi, good morning, everyone. Can you guys all hear me fine?
Yeah.
Okay. Yeah, it's kind of crazy. I think this is my third time speaking here, and you guys followed me throughout my whole journey as a firefighter medic. I think I started out, yeah, as CPR instructor,
Yes.
EMT. Now I'm here.
So thank you so much.
Yeah, thank you. So it's a pleasure to talk for you guys again. Again, my name's Alex Lee. I work for the San Jose Fire Department. I've been there for about a good year now. Got to see a couple of things. It's not really too different, I would say, from the ambulance life. You're still kind of responding to different patients that you meet, whoever calls 911. But there was a couple of things here that I kind of wanted to talk about, like what my day-to-day responsibilities kind of look like and the type of patients I interact with. Um, it's a lot of just dynamicness with this job. My day-to-day kind of starts out as I check out my equipment over at the station around 7 a.m. We run 48-hour shifts, so we get a little dorm, we get to sleep in the fire station and everything like that. But a lot of the calls that come in through 911, either if it's going to be something fire related or something medical related, we respond to all those, right? Earlier we were talking about like I heard a little bit about dangerous patients, drunk patients, and sometimes like we get to work with police and they'll clear the scene for us before we go in. But again, with how dynamic scenes can be, it can still be sort of dangerous when you go into a scene. That's why it's kind of important to kind of rely on your teammates and things like that before you even get to go and assess the patient. But that's part of why I really enjoy that job is kind of the dynamicness, and it's not really there always are protocols to keep you safe and things like that, but you're always on your feet. You're always thinking about not only like the medicine side, but also just making sure that you're safe as well, right? So my day to day, first I go on to the engine. I check where I'm staffed at first and foremost, but we have a lot of different equipment on our engines, a lot of diagnostic tools, not as much as how much there is in the hospital, but we have a life pack that can do, basic vital signs. You can run a 12 lead. You can kind of take a look at what's going on cardiac wise. We have a whole drug box. So as a paramedic, it's pretty different than an EMT. Mostly as EMT, you can administer things like oxygen, aspirin, but as you get your paramedic license, you can start administering different things as far as like cardiac drugs. You can start intubating, needle decompressions that was talked about earlier too. A lot of that is done in the field. We try to take a look at those as fast as we could, any type of life threats, and we're allowed to do those things in the field and then go over to the hospital itself. Um, but as far as how things has changed in the 911 system, as far as like firefighter paramedics, you would think we're responding to a lot of fire calls. That's not really true anymore. I would say 70 to 80% of our job nowadays is a lot of EMS. And so we work hand in hand pretty much with the ambulance crew. And then it depends on how critical a patient may be. We may ride in with them and help them triage over into the emergency department, working with nurses and doctors as well. My interactions with patients, it again is super dynamic. Sometimes you get anything and anyone that goes through the 911 system, right? Whether it's someone that maybe had too many drinks, someone that's having a cardiac event, and sometimes you may be working a cardiac arrest in someone's living room or someone's backyard. There's a lot of interesting places that I've worked a cardiac arrest before, like homeless encampments, people's backyards. You learn how to work with what you have, with what little you have inside of the fire engine. But my education and journey, it kind of started out back in 2020. I didn't know if I wanted to be a firefighter yet. I kind of wanted to get my feet wet with emergency medical services. So I started out as EMT. Programs for EMTs kind of range from like 1,000 to 2,000 if you have FAFSA. Some of those programs can actually be paid off if you go to like a public college. I went through the public college option and used FAFSA, and I had a little bit of time as a military veteran, so that was all paid off. But the schools are relatively short. Some programs are 8 weeks. Some maybe range to just one semester. And then you get to start working on an ambulance, which really helps you at least get dialed with at least learning how to talk to a patient. Because I always felt like the first year is just super difficult to try to even think about medicine. The first year is really just talking about like learning how to talk to a patient, learning how to introduce yourself, And then you kind of trickle into like figuring out what's going on with them, right? For my first 3 years, I worked as a interfacility transport EMT, which is pretty much just taking a stable patient from one destination to the other. I think that was pretty nice just because at least it gives you a chance to learn what a patient's medical history is, what medications they're taking, what it's indicated for, and it kind of really helped me lead into paramedic school, where sometimes when you meet patients, they're not going to tell you right away, like when you ask someone, what's your medical history? And they're just going to be, no, I'm completely healthy. That's usually the case most of the time. But then you start asking them, well, what medications do you take? And then they start giving you this list of medications. Learning those, at least as an EMT, helped me so much as far as being a paramedic and being a firefighter paramedic now, because you're almost, in a way, you're figuring out why they're taking that medication and you're figuring out what their medical history kind of is, right? So I did 6 months as an interfacility transport EMT. I did about 2.5 years as a 911 EMT, which is a lot different because now you're on a 911 ambulance. Whatever someone calls 911, you respond, you go there and you kind of check out what's going on. And then now I've been at the San Jose Fire Department for about a year, and the job is pretty similar as it is on the ambulance. It's just now, as far as meeting a patient, usually how it goes is someone calls 911, fire department meets them first, they transfer them over to the ambulance crew, and then they get transferred over to the emergency department. That is if they call 911, they don't go straight to the waiting room, right? But as far as like cost goes, a lot of it I went through Contra Costa College, which I would say it was like paid off by FAFSA and my military support as far as like payments go. But most paramedic programs, they kind of start out private programs like 10,000 to 13,000. But it's a super fast school. You go about 1 to 2 years in the paramedic program, and you get some pretty good experience, at least just finding a patient, and then you have to kind of figure out like a differential within the first like 3 to 5 minutes if you can. And then just learning how to interact with them. I just feel like a lot of that experience was super helpful, at least leading up to becoming a firefighter paramedic. And the last thing I have really is just like any advice for anyone that wants to go into healthcare. I think it's good for you guys to have like some sort of plan, but depending on how young you guys are, you don't have to go into and become a paramedic or even become a firefighter. I really do think a lot of students that I've met that pursued wanting to become a doctor or becoming a PA, nurse, they had a little bit of time as an EMT, and that little bit of exposure really helped them as far as their education goes in the future. Just seeing how a patient presents, learning medical history, learning super basic things really helped them progress as far as their career goes. But as far as like my day to day and everything that I do in the job, that's kind of it. I'm kind of open to like questions if you guys have any.
Can you real quick talk about the difference in training between an EMT and a paramedic?
Yeah. So as far as an EMT goes, the training that you undergo as EMT, they understand that you're coming in with zero medical experience. So they're almost working from the ground up. A lot of it has to go with the basics, ABCs, airway, breathing, and circulation. They teach you like very basic anatomy and physio. And there's only a couple of things that you can administer as an EMT, like aspirin. They tell you what aspirin is used for, what type of patients use oxygen. They even go as far as, teaching you how to connect nasal cannulas, non-rebreather masks into an oxygen bottle, and just kind of going through with like how much liters per minute even some of those need. But as you start out with the basics, as you progress through paramedic school, then they start introducing to you, how to read a 12 lead EKG in the field. What type of medications do we need? Do we need to bump up the heart rate? Do we need to slow down the heart rate? What do you do during a cardiac arrest? A lot of what they teach you in paramedic school is not just an increase in learning medicine, but learning how to be a leader as well. Because when you do become a paramedic, you do have on the field, you have the highest medical authority. So most people are looking at you for as far as like any type of guidance goes. And I mean, it's kind of hard to make those decisions right there and then, but that's what I really enjoyed as a part of paramedic school was learning how to become a leader itself. And I noticed there was a question here in the chat. Let me take a look at it. So the question is, how do you deal with high stress situations? And do you think you were always well suited to high stress situations in general, or is it something that comes with the training? That was a really good question. So I would say in general, I was never really good at high stress situations. I feel like when I started out as EMT, of course, like you're never going to be able to right away know how to deal with those high stress situations. But something that my preceptor taught me when I was going through my internship, and I'll go into a little bit of that after this, is sometimes you may not know what's going on with the patient because they could be presenting with a whole lot of different situations that or symptoms that you may be seeing. If you go back down to your ABCs, completely back to square one, that usually helps me in high stress situations, right? And you always try your best to take a step back and just breathe a little bit. There's a lot of times energy kind of moves. And when you go onto a scene, especially let's just take an example, a gunshot victim, a lot of it is super crazy on scene. There's a lot of phones out, there's blood everywhere. It's just like super scary. Sometimes it could look like Hollywood, but there's protocols in place. And although every patient is different, you can go back to your protocol and know exactly what to do. If someone gets shot, we're going to patch it up. We're going to control the bleeding. And then whatever else comes after that, we'll figure it out. If they need a needle decompression, we'll needle decompress. If they need an IV, of course, we're going to get IVs. But I feel like as far as high stress situation goes, you always have a protocol to go back into. There's some sort of algorithm that will help you go through that situation. And if they really don't fit in an algorithm, there's always something that you can do. Again, it goes back to ABCs. But as far as like the training for a paramedic goes, you go through a year of didactic, which is 1 year in the classroom. You get to do 6 months in the emergency department. So you get to shadow with a nurse who is your preceptor for about 6 months. And then once you're finished with that, that's like almost your chance to do as many IVs as you could. You can intubate as much as you can, as long as they allow it. And then for 6 other months, or the 6 remaining months, you go onto an ambulance and you're pretty much acting as the lead paramedic on the ambulance itself. So you finally get everything together, everything that you learned from didactic, everything that you learn in your clinical experience, and then it all goes into play during your internship. So again, overall, about 2 years for a paramedic student, but it's looking back at it, it was super fun just to go through all that again. And we have another question. Let's see. Was there a specific experience that made you want to pursue this career? There wasn't really like specific experience. I had done 4 years in the military, and it had nothing to do with medicine whatsoever. I was working on radars at that time. And as I was getting out, I was looking into careers in tech. But I just noticed, like, for me, I just really like working with people. I like interacting with people. I love problem solving. But I noticed my type of problem solving wasn't really towards like computers and things like that. It was more, I want to figure out like what's going on with you, what's wrong with you, and I want to try to help you as much as I could, right? That kind of led into a career into EMS. And as I started working in EMS, met a lot of different people, a lot of them being paramedics, being firefighters. And it just really, I really like that, the dynamicness of that career. It really made me want to go towards like, becoming a paramedic and then becoming a firefighter. Because again, as EMT, I really enjoyed my time as EMT, but I just felt like there wasn't much that I can do as far as an EMT goes. Your scope is really limited, especially in California. So that's why I wanted to pursue being a paramedic. There was a whole lot of more things I can do as a paramedic itself. Really good questions you guys have over here, though.
Does anyone else have any questions? Raise your hand. Anyone? I wanted to ask, are are you the one? So we heard from Dr. Sullivan before about the patients when they come into the emergency room, they've already sort of been de-escalated. So are you the position that would do the restraining, or if you have an out of control patient, are you the one that handle that first before they go into the emergency department?
Yeah, so again, there's even a protocol for de-escalation as well. We have physical restraints and chemical restraints, but we kind of have to gauge the situation on how bad it is, right? Sometimes it could be just like their history itself and how they presented on scene. We are allowed to physically restrain them. But as far as like de-escalation goes, if it's completely like we can't even get them into restraints, we need chemical restraints, and that's like using a benzodiazepine to kind of calm them down. As a paramedic, you're able to administer that and kind of calm them down a little bit. But as far as like trying our best to de-escalate, one of the things I enjoy about this job too is you do act as a partly like a therapist. Sometimes people call 911 and they just want to be heard out, right? They're super frustrated and they may be at their wits' end, and sometimes like just sitting them down and talking to them really helps the de-escalation. So we can go beyond the chemical restraints, the physical restraints, and sometimes just like talking to them itself kind of cools them down by the time they go into the emergency department. But again, if it gets completely way too rowdy, we do have the chance to use physical or chemical restraints.
Do you have a lot of repeat patients, folks that call 911 a lot?
You know, I worked in like 3 different counties, and yeah, I will say there are a lot of there's frequent flyers within like a certain geographical area. But what I notice is that when you go from different counties, it's a lot of the same types of patients. And I'm not saying everyone has like the same signs and symptoms, but you start noticing like a trend, right? Like it kind of goes back to even like if you get a chest pain call, if you start noticing that it's like sharp pain, but it doesn't radiate, but they breathe and it hurts, maybe you start thinking, okay, this could be musculoskeletal, versus a lot of different patients will present with that substernal chest pain radiating to the left arm, jaw pain. Okay, we're kind of thinking that this could be a heart attack, maybe an origin. So I would say like those type of patients, yeah, you kind of see like a trend as far as like the amount of patients that you see, right? Um, but a lot of the people that call 911, 10% of it, 10 to 15% of it is a real like, okay, we have to go really fast to the emergency room right now. But I would say like the rest really are, sometimes people are just having like a really bad time, and you got to kind of sit them down. And a lot of it is public education, right? Like I've met a lot of patients that would have a nosebleed, and sometimes they've never had a nosebleed before. And it really is about just sitting them down and telling them, hey, when you have a nosebleed, you got to at least pinch your nose. Because sometimes people don't know. Like they don't know much about medicine. They really maybe don't even know much about nosebleeds, fevers, or anything like that. But we come in as experts and we know this. And so we try our best to kind of be a therapist, but also to kind of teach them like, okay, in the future, if you have a nosebleed, pinch your nose, tilt your head down. Do you know what coagulation means? Well, that's where the blood pools and things like that. Um, Again, a lot of who people or what people are calling for as far as 911 is not exactly emergency. Sometimes they're non-emergent, but we come there to solve their problems.
How do you get into a locked house? If somebody calls 911 and the door is locked, how do you get in?
I mean, there's a lot of different ways. We try to go from least invasive to most invasive. So there's a lot of different things in our fire engine to go into homes. There's bolt cutters. We have this thing called irons, which is pretty much like this giant pick and then a flathead axe where you can like break open the door. But first, we try to at least go around the house. We try to see if there's any windows that are open. And then we have ladders as well, so we can always try to get into their second story window if we could. But if we really can't get in, if we can't manipulate any locks or anything like that, then we will have to break down the door. But we try our best to at least like wait until we exhausted all efforts to at least try to break down that door. But it's pretty rare for us to ever do that. I've only done that maybe like 3 times, and it's because someone calls 911 and they can't get up, and they've been laying there for maybe like a couple hours and they just can't get to the door. That's like really worst case scenario. I think I have a question right here from Jillian.
Hi, okay. So you were mentioning like before, like a lot of the calls you get like for 911, they are in actual emergencies. So do
Mhm.
you think like with the high number of like calls that like aren't emergencies, do you guys I mean I don't know you probably can't say, but like do you ever just like not answer 911 because it gets so annoying, especially if you had like with the nosebleed thing, like you had 3 different calls in a row, and it's just like, I got a nosebleed. And it's like, it kind of like defeats the purpose, I feel like, of 911.
Yeah, no, that's a good question. Like, as far as our policies go, we'll never deny anyone the right to calling 911, right? What we think an emergency is may not be an emergency to someone else, but that doesn't really take away their right of calling 911. But what we can do is there's a lot of different programs that we enact into our system. Like if we notice, let's just say this address has been calling 911 way too much. They've been flooding the 911 system. What we can do is at least provide them public education, maybe not through the fire department, but through the county. They'll reach out to them and they'll have someone called a nurse navigator and kind of talk them through, okay, what symptoms are you having? Like, is this truly a medical emergency? If not, here's the avenues that you can take. But as far as people calling 911, let's say it's just different people calling for the same thing. My job is always going to be the same. We're still going to treat it. We're still going to sit them down and try to talk to them, like educate them at least, like, this isn't really a medical emergency. You don't have to go through the ambulance to get to the emergency department. I would say like a good chunk of my job is just teaching people at least like what avenues they can take at least to go to emergency department, right? Because most people think again, there's different things that people grow up thinking. Oh, if I take an ambulance, I'm gonna get seen a lot faster. We try to shut that down as fast as we could because there's a triage system that works when you get into the emergency department. They check out how critical you really are, and sometimes you may take an ambulance, but you might be waiting like still the same amount of time as far as someone that drives to the hospital. But I would say we don't there's laws that protect a lot of citizens from things like that. We can't just say, no, you're having a nosebleed and then completely hang up. We're still going to respond and we're still going to treat every patient as best we could. Because the way I view patients is the way I view my sister, my wife, my mom, and my dad, and I just wouldn't like that if my mom didn't know what a nosebleed was and the paramedic comes in and they're like, oh man, you're a 4th nosebleed today. Like we try our best to handle it as much like dignity and respect as possible.
All right. All right. I think that's all the questions. So would everyone please thank Alex for jumping on the call and sharing his career with everyone. Thank you so much for joining us. Like you mentioned, we've seen you throughout your career, so this has been wonderful to see where you are now, and thank you very much.
Yeah, of course. Thank you, Sam. Thank you everyone for joining. If you guys want my contact information, if you guys are interested in this career, definitely reach out to Sam. Sam will give you guys my contact information. But it's been a pleasure to have you guys here today. I'll see you guys next year.
All right. Thank you.
All right. Have a good one.
All right, guys. So we did have a little bit of a change in plans. Our last speaker for the day had to reschedule, so we're working on getting her rescheduled. So we'll be done for today. Our winner of the gift card is Assis Garcha. So I will send you a gift card, but you're all set for today. You can head on out and we'll see you tomorrow.